Hi, everyone. Thank you for joining us.
Definitely. Thank you so much.
Yes. Happy to be here.
This is day 3 of Black in Cardio, and today we're focusing on vasculature. So we have two amazing women to join us today for this panel. I'll introduce myself first. My name is Jason Amate. I'm a PhD student at the University of Nottingham in England, and my research is focused on revascularization of ischemic diseases such as peripheral vascular disease. So I'm very excited about this conversation today and looking forward to hearing more about your research. Deborah?
So my name is Deborah Camille. Yeah. My name is Deborah Camille Mugaz. I am a postdoc at the University of Vermont, where I do study racial disparities in cardiovascular and cardiometabolic disorders. I work on the REGARDS study, which is one of the largest cohort studies in the United States when it comes to stroke and related diseases, including hypertension and diabetes. So do focus a lot on biomarkers of these diseases as they relate to racial disparities. Dr. Harris, I guess.
Oh, yes. So again, I'm Jen Harris. I'm currently a StrokeNet fellow at Columbia University Medical Center. I completed my vascular neurology fellowship actually last year already, and I'm there now for an extra research year. And my focus is essentially on health disparities, particularly in regards to stroke outcome.
Definitely. And Dr. Ross.
Hi, everyone. My name is Elsie Ross. I'm a vascular surgeon at Stanford School of Medicine. I am also a data scientist. I started on faculty about 2 years ago now. This is year 3. And I spend part of my time in the operating room and in clinic taking care of patients with vascular disease. And the other time, my other time is spent running a research lab where we use big data and informatics to try to come up with novel insights in terms of risk factors for vascular disease and to develop automated tools to improve care of the vascular patient.
Fantastic. That's amazing. So we've got some questions here for you, but we also are looking for the audience to throw in their questions as well. But just get the conversation started. A question that I actually wanted to ask, especially to you, Dr. Ross, was when people think of cardiovascular diseases, they think of maybe strokes, they think of heart diseases, and etc. How can we raise more awareness on diseases such as peripheral vascular disease? Because not many people do know about
diseases. Yes,
and it does affect a lot.
Oh no, I think he froze, but I totally understand what he's talking about. So, because as a vascular surgeon, I feel like we're like the runt of cardiovascular. Like cardiovascular really means the heart, and then the vascular system kind of gets lost in that, unfortunately. And so they've done studies before that showed that whereas like 70% of people you survey know what a stroke is or what a heart attack is, like only 25% of people even know what peripheral arterial disease is. So it's really hard to even get the disease diagnosed. And that's a lot of my research is, can we find ways to automate identifying patients so we can diagnose them earlier and put them on the right medications and get them the right treatment. I will say that one interesting fact that I think is important, especially in this forum, is that PAD, as I study it, which is atherosclerosis that affects the lower extremities that can lead to pain with walking, limb loss, and multiple other things like decreased quality of life. So PAD in and of itself, it has a higher prevalence in the African-American community in the United States. And yet it's not something we talk about a lot at our society meetings. It's not really written about that well, even though there is more and more disparities research in vascular disease. I think that point just needs to be broadcast, that like African Americans have a higher prevalence of PAD than other racial and ethnic groups. And so why is it that we're not diagnosing them at the same rate? The other issue is when you're not diagnosing diagnosed, then you're not on the right medication. So a lot of minority patients progress to more severe disease that leads to amputation, like disparities in amputation. And the other issue is that even if they're diagnosed, there are a lot of minorities who might not live in communities where they have access to vascular specialists who might do a lot of work to prevent amputation. So how do we raise awareness? Like, I bang the drum when I'm at research meetings to try to, really get put across the message that we're not diagnosing people at the right time, and there are racial groups that are suffering because of this. That's number one. Number two is I'm spending a lot more time these days doing community outreach. So tomorrow I'm actually speaking at an event for an organization that specifically is interested in increasing awareness of all types of diseases, but tomorrow we're focusing on vascular disease in African-American men who tend to not access healthcare at the same rates as other groups. And then just being scientific about our findings, publishing more widely, and just getting the message out there. I think it's a general issue of how do you get to populations who might not have access or want to access the healthcare system at a rate that other people do. But my solution is to use machine learning and AI to try to, improve that issue. Just because I think if you can automate it and bring it to someone's attention, that will increase awareness, even if they don't themselves study the disease or know that it exists. So a long-winded answer to your question, but I hope that answers it.
For sure. I think I cut out when I was asking the question, but you actually
that's okay.
It really well. Yes.
Okay, good.
Sorry, Deborah.
I did have a quick question for you about AIs. I mean, I think we keep on hearing, or we are hearing a lot more about these algorithms, even though they are, we're talking about machine learning and so forth, and big data, that there is this human component to big data, and where there is a human component, and in a society like the United States, you have to at times deal with issues of systemic racism, and that gets translated into these machine learning issues, especially when it comes to trying to predict outcomes and issues of health for Black patients. Yeah. Can you talk a little bit about it when it comes to these issues of the vasculature?
Yeah, so it's interesting because there are a lot of issues that come up. So recently, a couple of professors at Stanford published that a lot of AI models are trained in like three big cities or three big regionalities in the United States, because that's where a lot of the data comes from. Well, for people who live in rural areas or for people who are not well represented in those populations, then the features that the model are picking up might be biased towards people of a certain race or gender or what have you. The other issue that's gotten a lot of press recently too is that there was one model being used to try to predict who would need more healthcare resources, and it was predicting cost. And unfortunately, because African Americans don't access the healthcare system in the same way and as the same rate as other groups, their costs are actually lower. And so if you applied the model and the model was looking for people who were more costly, you would actually allocate more resources to Caucasian patients than you would to African American patients. And so there are all these issues that come up. And so right now, some people are thinking, should we have a separate field where we look for bias, not just in terms of race and ethnicity, but even gender bias or socioeconomic bias in machine learning models. Another issue and this is not the vasculature, but think about things like skin diseases, like melanoma, where if you're training models on people of a certain skin color and you give the model, you know, someone who's has more melanin, it's probably not going to perform as well. And so if you hang your hat on using machine learning models without understanding what types of biases may exist, then you might completely disadvantage a group of people who are already disadvantaged. So the answers to how we account for that bias, I think, are still forthcoming and may take on a field of its own. In terms of my research, I use electronic health record data primarily, where my lab is also starting to look into imaging data and genetic data. So the great thing about imaging data is it's all like perfusion, right? So you hopefully in terms of building models that use that type of data, there's less bias, but we don't know that. And it's just something that I continue to keep at the back of my head is how do we test to see if these models are disadvantaging one group or the other. In terms of electronic health record data, we've actually decided not to use race or ethnicity in our models and instead try to use the clinical factors and healthcare utilization factors that may predict whether someone will go on to have an adverse cardiovascular event or whether someone's at high risk of having PAD. Having said that, we're training models at very high level institutions where the racial mixes are different. So my solution to that is to bring in data from multiple health systems where the proportion of minority patients differs and to try to enrich the model with more minority patients so that we can be less biased. And then to also test these models and see and account for whether we are demonstrating any bias across race. But I think there's more awareness about potential biases, and hopefully that means that we'll have more tools and we'll have better studies about how we can account for it.
Definitely. Thank you so much. Thank you so much. I don't know if Jason had another question with regards to the work that you do.
I actually had a question for Dr. Harris. I wanted to ask you what got you into stroke research? What drove you into this career path?
Well, for me, I mean, you know, when I was an undergrad, I was a psych major and I was always interested in like behavior and the brain. And when I did my medical school rotations in neurology, I was like really drawn to stroke. It's very fast paced. It's acute care. Patients are sick. It's very interdisciplinary, which I loved. And then in regards to stroke research and health disparities, it's basically, I mean, you know, African Americans are still at a higher risk for stroke. They have a higher stroke incidence, and there's just so much to do. So I just was really drawn to this field.
For sure.
And I do have a quick question. So, sorry, I was saying that I do have a question. I do have a quick question. So like I told you, I do work on the regards, which is one of the biggest study, if not the biggest study with regards to racial differences and geographic differences in stroke risk and prevalence and so forth. So what regards has shown in a study is that almost more than half of the racial disparity in stroke is explained by traditional risk factors, and the other half is unknown. So according to you, what do you think might be other factors that have not been previously analyzed that could potentially explain the rest of the disparity?
Yeah, this is so interesting because this brings me to the research that I'm doing right now at Columbia as a StrokeNet fellow, because when you look at the regard study, like you said, right, when they take an African-American person and a white person with the same stroke risk factors, same healthcare access, socioeconomic levels, whatnot, the African-American person will still do worse. So clearly we must be missing something, right? So my mentor, Dr. Randy Marshall, actually, he came across this concept of allostatic load, which actually has been studied already in the cardiovascular world, but not as much in stroke. And essentially what that concept is that people who have constant societal pressures such as racism, poverty, and whatnot, instead of their homeostasis being here, it might be up here. They have a new set level, and that level is called allostatic load. And you can measure it with certain lab values such as cortisol, DHEA, and many others, as well as clinical measures such as heart rate, blood pressure, and whatnot. And essentially what they found in the cardiovascular world is that minorities, and particularly African Americans, tend to have higher allostatic load and also have worse outcomes. So what we're doing with my project right now is basically applying that to stroke. We're having a prospective study going on where we're enrolling patients from the stroke service. They fill out a survey, which is mostly stress-related questions. We later on analyze all their, we have an allostatic load score where we basically accounting for certain like lab measures and clinical measures, and essentially wanted to look at if certain minorities do have a higher allostatic load score and if it somehow predicts a stroke outcome. Because as you mentioned, it's like, and not only the regards, I mean, there's so many studies out there that adjust for quite a lot of, confounders, and African Americans still do worse. So clearly we must be missing something.
Yes, definitely. And it's so interesting that you are mentioning allostatic load, because right now we are dealing with some of these issues with regards to COVID-19 and some biological responses that we don't understand. So I'm doing an analysis, or I've done an analysis where we do see some differences in biological responses that even though you do adjust for all of these different socioeconomic and clinical factors, they're still there. So something might be happening there. And I think I think we have to start exploring it a little bit more. But like you said, even though we are looking at allostatic load, we are also trying to understand issues like systemic racism. And as I always say, we are trying to quantify social concepts, and that's going to be an interesting thing to do, definitely. I don't know if Jason has any other comment or questions about it.
To follow up, you mentioned the social issues that can affect these diseases. So my question is, how do we as scientists incorporate that into our research going into the future? How do we show that? Because I think we are really good at communicating. Well, actually, no, we're not very good at communicating science to people. But how do we basically bring those factors in to show that we are accounting for those issues as well?
Yeah, honestly, I think the most important thing, just as Dr. Ross already mentioned, is honestly prevention and going into the community. And because, if you look at the AHA data, the American Heart Association, even though stroke rates overall have decreased in the last decade, which is great. But when you look at African Americans, they still have a threefold higher stroke incidence than whites, and also way worse mortality. So honestly, I think that one of the most important things actually is just prevention to begin with. I know we like to focus on interventions, especially in stroke. It's all hot and sexy, like the acute stroke management, but honestly, the focus should really be in going into the community. For example, at Columbia, we have a project, it's called a Hip Hop Stroke Project, which is led by G.D. Williams. And essentially, we have workers that go, and ourselves too, we go into the community, we work with churches, and, just to raise awareness. Because again, when they did studies about, it's similar to what Dr. Ross said, that African Americans seek stroke care in a delayed fashion, because probably there's a lack of awareness of stroke symptoms and how serious it is. So I think that honestly, first of all, prevention is where it's at, and then also there's a lot of focus on like why we have these disparities, but not really much on actually an intervention. So I mean, it's difficult, right? Because it's at a society level that you have to really intervene. But what's nice about allostatic load also is that they did some studies, again, in cardiovascular, more cardiovascular rather than stroke, but where they found that, people, for example, who have a positive racial image or who do meditation and all these things, like they actually have a buffer from that allostatic load, even though they have a higher allostatic load, they might, the effects don't affect them as bad as others. So, that's why it's nice with the allostatic load, you can already start at the individual level. But of course, I agree, at the end, it needs to be societal interventions.
Definitely. I think it's refreshing to hear you talk about prevention as opposed to, I think sometimes we, like you said, we do focus a lot on treating and treating and treating, but actually we need to go into these communities to stop it in the first place, because yeah. Sorry, Deborah, I think you were about to say something.
No, I think apparently there are questions that are being asked on YouTube, so we wanted to double check and see what was happening there, because the public is getting very interested in these issues with regards to stroke and with regards to all these different social aspects of it. But Jason, I'll let you continue and say what you were trying to say, and then we'll go from there.
I think I cut out. Sorry.
Yes, you're saying something.
No, yeah. So so to bring it back to kind of like prevention and healthy lifestyle, how do we because bringing it back to talk about how scientists we talk about the science and we talk about the factors and all of that. How do we show that this is as important as so? How do we show the community that this is also very important, to look after yourself, to eat right, to exercise, to all those things that we talk about that are important to prevent these risks? How do we incorporate that into our research, like into our papers, into our studies, and make it more accessible for the community? Because when we write papers, because we don't communicate it well, not everyone gets to read those papers. So how do we get, I don't know if you understand the question I'm trying to ask, basically.
No, I do. I do understand. I think like you definitely, I mean, the papers that we, that we write and whatnot, like they don't reach the community. So I honestly, the only way I can think of reaching the community is by, exactly like Dr. Ross does tomorrow, go to the community, right? Spread awareness, work with churches, work with barbershops, whatnot. I think this is really the way to go in regards to how to raise the issue and make it so that other scientists understand how important it is. I feel like, I mean, we all know it's important. I mean, it's like, how can I describe? Maybe Dr. Ross has any other solutions, but I do think that going into the community is like the way to go.
I think part of it too is coming to terms with the fact that we've been communicating in a way that is conducive to a majority population that might not ring a bell or ring true for minority populations. And so even the messaging about what it means to eat healthy and how to eat healthy and what foods to eat, there is some, culture and ethnicity that I think that we don't focus on as much as we could. So having tailored messaging, for instance, like if I tell my African-American patient to eat healthy, what does that mean to her? To her, it might just be that she's not drinking as much sugary beverages, or does that mean that instead of eating one type of meal, she eats a different type of meal? It's all very confusing, and we just assume that when we say eat healthy, it means the same thing to the different people. And I think maybe some more culturally relevant, tailored messaging would be better. I also think social media, I mean, it's a double-edged sword. Like there's a lot of misinformation that gets spread on social media, but I'm heartened by all of you guys who are doing something like this, Black in Cardio, where we're spreading the message on social media so that it's more accessible to people who don't necessarily, like you said, read journals, which are behind a paywall, and they don't have the same expertise to even tease out what we're trying to say. So maybe that's, and that also gets to the whole issue with representation, having more people in, cardiovascular science at universities who are interested in reaching this population. Like I do a lot of this for my mom, who her daughter is in cardiovascular health, and it took me years to get her to take blood pressure medication, So when I think about outreach and improving healthcare for African-American communities and minority communities, I think from the perspective of someone like my mom who has no healthcare background and for many reasons might not want to engage in healthcare healthcare, but so how do I tailor my message to get it? Because if I tell her, take this medication so you don't have a stroke, like what's a stroke? What is that even going to look like? Like, why should she be concerned? And so you have to kind of see it from someone else's perspective. And we tailor our messages to people and we think that they get it when, to be honest, they often don't.
I completely agree. It's so important to like culturally tailor your message. It's a very good point.
Definitely.
For sure.
And Dr. Dr. Harris, Dr. Mary Cushman, who is one of the PIs for the regard and who is my mentor, just said that great to be here, and thanks for the spotlight on vascular diseases. And she said that we have allostatic load assessed in regards. If you want to collaborate, we will be willing to do it.
I would love that. Let me tell Randy Marshall, my my mentor, but that would be amazing. I mean, I'm sure you would be thrilled to hear that. I will reach out to her.
Definitely.
I follow her on Twitter. So.
Definitely, and this is what we're trying to do. We are trying to breed collaboration so that we can definitely start addressing some of these issues of racial disparities in these vascular diseases. And just as a quick side note, people on Twitter, on YouTube, on Facebook, if you do have questions for our guests, feel free to ask them. We want to reach out to the public. Like we said, it's a matter of accessibility. We want to make sure that you understand the information, and you want to make sure that you understand how the information relates to your own life. So I will let Jason take it over, because I think you had a question before I interrupted you.
Still sticking on the same point. So actually, this is quite a broad question in the sense that, do you think we should, as scientists and doctors, do you think that we should have training in communicating our research? Do you think that should be part of the training? And how do we go about that? This is to both of you. So
say that again. What kind of part we should have? What kind of training?
So should we have communicating our research, so science communication, as part of our training, so that we can disseminate this information to the public a lot better than we do now?
I think that would be a great idea to have some training in health communication in regards to, as you and Dr. Ross already mentioned, in order to like make our message more generalizable and to reach the actual audience that we want to reach. But I wouldn't really know how to. I mean, I guess in medical school you could have classes.
Yeah, I think medical school is a good entree to community, or a good forum for improving communication. For PhDs, I think just having that class in the first 2 years when you're doing more classwork might be helpful as well. I found it helpful to take certain seminars, but it's really spotty. It's like here and there, like how to communicate with the public or how to communicate your message. And it's like a 1 hour thing and you try to get as much from it, but obviously we could be doing a lot better. And I just don't even know if there are organizations specifically for, scientific communication. I think major universities have a communications division or department that kind of will help in some ways make the science more palatable. But again, we're running these stories in forms that may not be accessible to everyone. So I think even with that piece, we have to think a little bit more deeply about what's the message, and then where do we put this message? Because not everyone's on Stanford's website waiting for the latest and greatest on stroke prevention or, vascular disease. And for me, like I've had experience, like I do big data, but before then I was interested a lot in health policy and studied that for a while. And so I'm also always interested in, like, from the public health policy perspective, how do we maybe not not penalize people, but how do we encourage organizations to put more effort into reaching different communities rather than just putting a message out there into the ether and hoping that it sticks or, you know, the right person hears it.
And I think that's what is so interesting with Black in Cardio, is we are trying to communicate science in a different way. And all these Black in X events, we are trying to communicate science in a different way, because a lot of our generation are on social media, and what people don't understand is different social media appeal to a different set of people. So right now, if you want to reach people 18 to 24 or below, you might have to do something on TikTok. You might want to translate your science on TikTok. And I've seen a lot of TikTok videos with doctors trying to actually show their science to the public in that way. And if you go to Twitter, maybe then you'll meet a certain generation, like maybe millennials and older millennials, and maybe also the older generation. If you go to Facebook, you also have a different generation. And based on the medium that you do use, you will have to also, the style of communication is going to differ. And I think a lot of the work right now is very informal, like the way that it's happening, the science communication on social media, the way that it's happening is very informal. But I think at some point we have to start formalizing it to make sure that we can actually transmit the knowledge, because there are a lot of amazing science communicators on Twitter. So on Twitter, on Facebook, on Instagram, like I can think of, for instance, the Researcher, who has an amazing podcast. We have STEM Noir, we have Black women PhDs. We have all these different spaces where science communication is being done. But I think we need to shed a light on them, because a lot of them are Black women doing this kind of work. Just shed a light on them and allowing them to actually help us transmit our science, because we are existing in a very specific period of time where science is very important. The way that we talk about science is very, very important. So I guess, Jason, you had a question. I'm sorry for interrupting you.
Oh, I wanted, can I add something to this?
Of course.
I want to add another real, keeping it real. Like when I look at my track to promotion, whether or not a community or a group of people understands my science, outside of a very small group of people at my university is not considered. So to be honest, no one cares if I'm communicating my science to, you know, minority populations or underserved populations. They care how many like publications I have, what their impact is, like how many patients I treat in clinic. There is no real incentive, I think, for a lot of scientists to try to make things more accessible. And so again, on this idea of like, is there something we can change from policy perspective? And we can look at bigger institutions who have the power to do this. Like, can people get credit or attention for trying to be more engaged in community education and learning and teaching? So again, I would say that's a major barrier, is if your promotion process doesn't hinge on things that are like that we're talking about, then people are just not going to do a lot of it.
Yes, and I think it comes down to this sort of tax that is we expect people, Black people or people of color to have when they come into these spaces, because when you come into this space, you are a community. At least for me, a community propelled you there, so you feel the need to give back to the community. You do understand that you have to, you do understand that your career hinges on you producing these papers, going to these conferences, or just doing things that are expected within at least these academic spaces. But at the same time, there is these expectations that because you are the trailblazer, because you are one of the only ones, that you will do something for the community. You cannot just get there and forget about the community. You are doing something as important as cardiovascular health or COVID studies. You better give back at some point. So I think it's an interesting space to exist in when you are a Black person in the United States or in the UK or even back home on the African continent.
Yes, so yes.
I think I interrupted you, Jason. Sorry.
So I was going to ask Dr. Ross about her event that she's doing tomorrow. So how did you create such an event, and how do we mimic it? For example, in the UK, how would we go about creating an event that's not just about the science, but it's just about going into the community and raising awareness and about all these diseases and issues?
Right. So the event, I had no part in putting together. I was just an invited speaker, so I'm not even going to take credit for all that. But the interesting part of it is, so Stanford does try to do outreach to different communities, like Dr. Harris was mentioning about some of the organizations at Columbia. And so in conversation mentioned to someone in marketing that I was interested in community engagement and education. And they had a connection to someone who actually is in Sacramento, a woman who wants to improve health outcomes for African-American men in particular, because her son died of a condition that she felt that if he had gone to the doctor, he wouldn't have, had such a bad outcome. So she's very passionate about inviting speakers. And so it was just like, serendipity that this all got put together. But being part of this makes me even more excited to be more engaged in the future. And so then the question is, how do we make it easier for scientists to engage with the community? And I think this is the right time, especially if you're at a university doing research, to bring these issues up, so that it's not just part of serendipitous happenings, but like, can you create a way, like a channel for this, so that it's kind of plug and play? So one month it's about, cardiovascular health, another month it's about urology and prostate or cancer or whatever. And so I think we have the opportunity now to be really creative about how we want to engage people not typically in our ivory tower. And it might mean not necessarily going through the usual channels, but this, is being put on through cardiovascular, the Stanford Hospital Cardiovascular Institute and marketing. So looking to other groups at your institution to see like, who's interested, who has some funding, and how can you funding for this event comes from both Stanford Hospital and some of the companies that, some of the device companies that have money for community engagement events. So I wouldn't say to just stick with one path, but there are multiple avenues to outreach.
I agree. And just to
No, carry on. I was just saying that was good advice.
Oh yeah, I know this is great. I just want to also bring it back to what Dr. Ross mentioned of tailoring it to the population that you want to reach, because this is nice about the hip hop stroke project at Columbia, is where they go to high schools and they're using like hip hop and rap to teach young kids about stroke symptoms. So if this were to happen in their family, that actually we had like kids calling 911. So it's just like again, instead of just going there saying like, oh, don't eat this and do this and that, like you really have to tailor it to the population you're trying to reach. So, and there are ways to do that. So.
And the event tomorrow is like, it's a jazz concert and we're going to talk about health, So, sometimes you got to sweeten the deal to get people to sit around and listen to things that they're not hearing on a day-to-day basis.
So true.
Yes, I think it's really trying to find these other ways to engage people is going to be very important, because one thing that we do know, and there's this HA study that has been published recently, where, I mean, we are talking about the vasculature, so I'll go a bit tangent, talking about heart disease, and just people knowing that heart disease and all these cardiovascular diseases are the #1 killer in the world and in the United States. People don't necessarily know that, and this awareness has decreased over the years. So we are really trying to raise awareness on something that is truly affecting people, and they don't necessarily realize that whatever they are dealing with, don't really think of things like hypertension, diet, physical activity, and how that's going to increase your risk of death. So I think having events like this where you engage the community differently are going to be very important in the long haul. So, Jason, did you have another question?
We have a question from Twitter, and it's from Dr. Dapo, and it says, so recent circulation papers show that Black women were less aware that heart disease was the leading cause of death among women. How can the messaging around heart disease be changed to acknowledge the issues of disparities in awareness?
Yeah, so one way that immediately comes to mind, and I'm going to give a shout out to one of my colleagues who does research at UC Davis, specifically focused on African American women. And her name is Dr. Candace Price, and her interest is specifically in sugar sweetened beverages, because it is these types of beverages tend to be consumed most by African Americans, but then again by African American women. And so again, in terms of the messaging on how you try to increase awareness, it's, well, what are the trigger points or the entry to having cardiovascular disease in this community? Is it certain types of foods? Is it certain types of activities? And so addressing those rather than general messaging, I think might be important to increasing awareness. So if you have, if you're interested in messaging for decreasing sugar sweetened beverage consumption, that can be very specific to a community where that is a factor that increases like diabetes, which then will lead to other cardiovascular diseases. So trying to understand what the trigger points are and messaging around that rather than general messaging.
Thank you. If any of the...
Definitely. And Dr. You can go on.
Sorry, no, yeah, I completely agree with Dr. Ross that, you know, rather than the general messaging, just like as we discussed earlier, it's probably not the way to go, and rather be more specific in regards to what leads to these diseases. And as we know, African Americans do have a higher incidence of, you know, hypertension, diabetes, and all these other stroke risk factors. So just going, you know, back to why this is the reason, such as she said, you know, maybe higher consumption of certain beverages and this and that probably would help.
Definitely. I guess we're going to pivot a little bit to your careers and some of the advice you can give to young scientists or young clinicians that are just starting out. So and we've been asking this question to a lot of our speakers. How do you deal with imposter syndrome? Because you are in these spaces and there are very few of us in these spaces. How do you handle imposter syndrome?
Yeah, that's a good question. I definitely had and still have imposter syndrome. I had it in residency, med school. You know, there are these thoughts that where you just feel like, how did I get here? Like, you know, am I a fraud and whatnot? And honestly, what kind of helped, I must say, is like just being on Twitter and seeing all these other like very, very successful scientists and physicians that say that they have imposter syndrome, and I look at them and I'm like, why would you have imposter syndrome? You're so accomplished and you're so like, you're an expert in your field. So then I realized it's probably really just something in my head, to be honest. And what I started doing, and I don't know if this would help others, but it helped me, is just like trying to change the way I think about it. So when I have these negative thoughts, like I just try to rephrase them, and I try to like do like positive affirmation, and just like try to really internalize and own my success. I don't know if this makes sense to others, but like really just like trying to restructure your thinking, and that you belong there and everything. But that's what I do. Like that really has helped. That helps me.
Definitely.
Yeah, I think
What about you, Dr. Ross?
I have a very similar approach to Dr. Harris, which is to try to restructure your thinking. So for me, it's that, I might not be, so like I have amazing mentors who are doing great things every day, and I'm just like, I'm never going to reach there. But then I try to think of like, what do I add to this equation? So in medical school, and I'm going to like switch over as, because my battery's about to die, but in medical school, I had imposter syndrome because I had all these colleagues that I felt were way smarter than I was. But I'm like, you know what? I really try to engage with patients, and I'm really good at that. And I'll, learn what I need to learn, and I'll be a great doctor eventually. So restructuring it to say like what I'm adding to the equation. I would also say that like everyone has their value add. And you just have to figure out what yours is and hone in on that, and make it an important part of your career, so that, even if you're suffering from imposter syndrome, you feel like at least there's this one thing you do really, really well.
Okay. Jason, do you have a question?
Yes. So if you were to say what's the monumental point in your career that led you to where you are right now? To either of you.
What was the trigger point?
Yeah, for me, the trigger point. So, actually, when I went to Queens College here in New York City, and I was a psych major. I actually graduated already and wanted to do a PhD in psych. And what happened is that just as I was about to graduate, I started volunteering in the St. Luke's emergency room here in New York City, and that totally changed my entire career path, because I really fell in love with medicine at the time. And also what really drove me towards like being involved with healthcare disparities was also working in that emergency room, because coming from Germany, where like our emergency rooms when I grew up, they were empty, right? Because it's like we only go to the emergency room if there's an emergency. But then when I came here and it was so packed, and with all these conditions that could have been seen by a primary care provider if these patients had access to it. So that really, like, honestly, it was like a shock for me. And from that moment, I knew I wanted to be involved in medicine, and particularly in regards to changing healthcare disparities. So then I actually re-enrolled into Queens College for a post-bac, and then eventually got into medical school. But for me, honestly, I still remember that moment where I was like, wow, this was really shocking for me.
So yeah, speaking of it, your experience. So did you have? So when did you come to the United States? Was it for your undergrad, or did you do your undergrad in Germany before moving to the United States?
Yeah, so actually I came, it was really, it's actually a long-winded, crazy story, but I came to many years to visit my friend. She was an au pair in Long Island, and I just was supposed to visit her. But then I fell in love with New York City, and I have dual citizenship. So at that point I was like, I'm not gonna go back, I'm just gonna stay here. So I found a job. I was just waitressing, and then I enrolled into Queens College, and then, little things added up, and eventually I became a doctor. But I didn't come here to study. I actually just came here to visit a friend, and then just never left. So
what about you, Dr. Ross? What was that monumental point, or that trigger point really made your career, made you realize that you wanted to do what you are doing right now?
So I am Nigerian. I was born in Nigeria, came here when I was 3 years old with my mom, who raised me and my brother as a single parent. And we both had sickle cell. And so I, from very early on, knew I wanted to be a doctor because I wanted to treat kids like me. And so when I went to medical school, I said, okay, I'm going to be a pediatrician and I'm going to be a pediatric hematologist, just like, you know, the doctors that treated me when I was a kid. And then I left to do a master's in health policy. I came back to medical school and then I did my surgery rotation and I was like, oh, maybe I want to be a surgeon. And so I went down that rabbit hole for a little bit. And when I rotated on different services, I actually love vascular because number one, I love the people. They were just, of the surgeons, they seemed to be like the people that I thought the most like. And they're really welcoming and provided a lot of opportunities to explore the field in terms of the clinical possibilities and the research. So, and at the time they had just started a 5-year vascular program as opposed to going through general surgery, then vascular surgery. So for a lot of reasons, it all just kind of clicked for me. And so I said goodbye to this like whole life that I had built for myself as a pediatric hematologist and then eventually a pediatric neurologist and now a vascular surgeon. And so after I decided I wanted to do vascular, then it became like, what was I going to do as my research? Because I always knew that I wanted to be a physician scientist. And so Stanford at the time was building this great informatics division. And I lucked into finding a mentor that, again, thought very similarly to how I did about how we use data. And so I took a couple classes to refresh some programming skills, learned how to program, run machine learning models. And again, just having excellent mentorship and support in terms of what I wanted to do. But it like I say all this to say that like I had my plan, I came to medical school, like saying I was going to do one thing, and then everything turned as soon as I hit, you know, clinical rotation. So I would say maybe clinical rotations were what really changed the trajectory of my career.
Yeah, I just want to say, if any med students listen, like definitely keep your options open because this happens all the time in medical school. You come in there, you think like, oh, I'm going to do psychiatry, and then you end up neurosurgeon or something like this. So definitely keep your options open during your rotations.
Dr. Ross.
So, sorry, go ahead, Jason.
I saw that you did a master's in England, right?
Yes.
How was that? What was your experience over here?
It was amazing. It was absolutely amazing. I did a master's both at the London School of Economics and London School of Hygiene and Tropical Medicine. Again, because my brain works in these weird ways, but I wanted to kind of integrate health policy and health economics and public health. And what I loved about the UK and London specifically was like, I thought growing up in New York, I was like in the most international city there is. And I'm not going to take that away from Dr. Harris because New York is an amazing city. But like, I feel like New York is like the capital of the Western world and London is like the capital of the rest of the world. Like there's just so much going on in the world, and when you live in the United States you just get a little glimpse of it, but living in a place like London in the United Kingdom, you just get so much broader exposure about what's really driving international politics, health, etc. So it was amazing. Plus there are like 6 airports around London, so I would just like pick a place and pick a weekend and fly around. So it was a great experience. I mean, it wasn't and that's to say, again, for any medical students on the call, like sometimes just take a chance on something that you think is just tangential, because that year away let me really think about what I wanted to give back. And also that was the year that Barack Obama was elected president of the United States. So seeing it from the other side of the pond was amazing. I still have like some London Times newspaper with his like face on it. So yeah, it was a great year.
Sounds amazing.
And Jason, I think we have a question. So Dr. Dapo is asking, how would you all convince a college student to pursue a career in a medicine and disease?
How we would pursue a college student to go into medicine?
So how do you convince a college student to go into medicine and cardiovascular disease or do cardiovascular medicine?
I mean, honestly, I feel like there's so many college students that want to go into medicine. I don't think that I don't think that they need much convincing, but in regards to going into cardiovascular disease and particularly stroke, what I really love about stroke is, again, it's very interdisciplinary. You work with cardiology very closely, with neurosurgery, with PM&R. I mean, all these great other specialties. Again, there's so much research going on in stroke. I mean, not only acute management, but prevention, everything. Like honestly, stroke management in the past 10 years has like completely changed. So there's so much research going on in that regard. And then the other thing is, again, you really make a change, honestly, in a person's life. So sometimes with neurology, and neurology is great, but we diagnose certain diseases and it's hard to treat them, if at all. But with stroke, like you can have a patient coming in barely able to talk or to walk, very disabled, and you have them undergo an intervention such as a thrombectomy, and they can be back to normal. So it's like really, and I've seen this like several times already. So it's like really, it's a very how do you say? God, what's the word in English? You get a lot of rewards, like seeing patients getting better.
Yes.
So it's a great specialty. You get research, working with all the other specialties. It's I highly encourage people to go into stroke.
Yeah, so
Definitely.
in a similar vein to Dr. Harris, I feel like it's hard. I tend to not want to convince anyone to do anything that I do because, to be honest, it's a really hard road. And so you have to want to do it for the right reasons. But I would say if you want to encourage people to explore the opportunities, then I think exposure. So for me, surgery was not on my radar, but scrubbing in and exposure to what a surgical field looked like was what did it for me. That one day that I went into that OR, I was sold. And so it could be similar to a college student, have them shadow a physician, multiple different types of specialties in different areas to see if that's something they can see themselves doing. I would say part of the reason I did vascular surgery and wanted to focus on cardiovascular disease is because it's an opportunity both for fascinating science, from basic science all the way up to implementation science, but also it's a field that touches on disparities. I knew going into it that African Americans and other minorities were not getting the same health outcomes. And so I felt like it would be a way for me to address the disparity issues through my research and through what I do on a day-to-day basis.
Definitely. I don't know if Jason has any other questions for our speakers.
Yes, I do. You both do. So you're both in the clinic and in research. How do you find the balance between both? How does that work for you?
Well, for me, last year I was most only clinically. Because I was an actual stroke fellow. This year, because I'm a stroke net fellow, I'm almost all research and barely clinically. So for me, it's easy right now. So I think it's a better question for Dr. Ross, because you're probably doing both at the moment. For me, it's really just a research year.
Yeah, it's difficult to balance both of them. I mean, my general recommendation is, in the course of your training, if you can take time out to focus on the research, whether that's 1 or 2 years or more, so that when you go back to doing your clinical work, you already have that expertise that you continue to build upon. Collaborating with other people who share specific expertise that you need to move a study forward is another way to try to balance it all. And just setting goals and being aware of where you're at. So if your goal is to get a grant, so my first year, I was building a practice, but then any extra time I had, and I asked specifically for extra time to write a grant so that I would have even more time to pursue my research and not just get behind by doing all clinical all the time.
Awesome.
And I think we have a question, yes, from Makeda, and I guess I can allow her to speak if she's willing to talk and ask her question. So Makeda, you can talk.
Yep. Can you hear me?
Yeah.
Okay.
Yes, we can.
Yeah. My question is just, I found myself during my training in situations where, say, a professor wanted to talk about a study that talked about racial disparities, but usually the conversation kind of tends towards pathologizing the non-white race that's being talked about. And you guys are familiar with this, where the conversation goes, Black people are more likely to have X, Y, and Z, without really asking about some of the cultural or systemic or any other features that lead into that. And instead you just get this conversation that says this Black body is more, broken, for instance. That's kind of how the conversation generally tends to go, or less healthy just in general than this, other standard. And so I'm just wondering, what are some tips about how to contribute to those conversations in a way that is useful and steers this conversation away from this pathologizing of these race-associated elements?
I think that's very interesting. I took a class in undergrad, and I will never forget this exchange, but it was on the interracial, like just race in America, and we were talking about interracial culture and all this other stuff. And so again, some of this would come up, well, African Americans or Blacks are more likely to do X, Y, and Z. And the professor just like stood there and said, stop. We are making huge assumptions based on anecdotal data or your anecdotal experience, and that's not based in data. And so just making it a moment where people actually abruptly need to check where they're coming from and what assumptions they're making about African Americans, and whether that be their health or their social status, I think was, at least in that setting, important, because I think a lot of when people do try to quote unquote pathologize, it is from anecdotal stuff. And so if there's any way to bring more data to the table about like why African Americans experience one thing or the other, or if it's really true what someone is saying about something that sounds bad about African Americans, is important, because I think we have to get away from anecdotal evidence and really get down to what the data says about certain things, rather than just having these conversations that are not helpful.
Yeah, I completely agree with Dr. Ross that we have to get away from that. And also, I know it's hard when your superior says something like this, but it's really important to, like she mentioned, just say kind of say stop and mention that why, right, certain things are more common in the African American community, and bring it back to like a health disparity such as access to healthcare, poverty and whatnot, right? It's like, yes, we see more strokes in African Americans, more hypertension and whatnot, but it's not, there might be like some genetic factor, but we all know that there's more to that, right? So it's, you always have to bring it back to why. It's the same like with when we say like, oh, this patient is non-compliant or doesn't come to clinic, right? It's like, we should ask ourselves why, right? Like, can they afford the medication? Do they really understand, did we make it clear like why they have to take it? Or can a person not come to clinic because they don't have childcare at home and all these things? So it's like very easy to be very dismissive, but we should always try to, ourselves think about it, and then have others also like make others aware that there are reasons for that, right?
Definitely. Thank you so much for your time. I don't know if Jason has anything else to add, but I'm very pleased, and we are very happy that you were able to share your experiences with us. And so I'll let Jason go ahead and say something.
No, I was just going to say thank you again for your time. Thank you for taking the time out to join us this week. We've learned a lot, and it's been amazing to hear about your experiences. So yeah, thank you.
Yeah, thanks for having me.
Yeah, thank you so much for having me. I appreciate it. It was so nice.
Yeah,
definitely. Thank you. Have a nice day.
Thanks, you guys.
Take care.
Bye.
Bye.